Hello, friends. Welcome to my presentation. My name is Shannon Thomas, and I'm a licensed clinical social worker and a certified financial planner. And I feel delighted to talk to you today about the problem of financial toxicity. I have to be completely honest. This is a new experience for me. I've never given a virtual presentation. I expect one of the challenges is that I do not get to see my audience, but I'm assuming today in the audience, there are many, many healthcare professionals. So I thought I would start with a little bit of a healthcare themed joke. So here's my shot at virtual comedy. What's the difference between a healthcare employee and our national healthcare system? Well, the difference is simple. A healthcare employee actually works. Now, hopefully I made somebody laugh at their computer today. Me, I'm getting the same response that I'm used to when I tell a joke, and that is absolute silence. That is making me feel normal in this virtual space. So I say all this tongue in cheek because one of the sad side effects or problems of our national health system that does not work very well is financial toxicity. Financial toxicity. Which can be described as a negative clinical, financial, and psychosocial side effect due to the high cost of medical care. It can create and cause distress with quality of life, create barriers to medical care, and it impedes access to basic needs. And it can also reduce treatment response. This is an important issue because our national health system puts us all at risk. 1 in 3 of us will experience a financial hardship this year because of medical care. But cancer patients are at even higher risk. According to the CDC, 3 out of 4 cancer patients experience financial burdens related to care. This is known as cancer-related financial toxicity, or CRFT. Cancer patients pay about twice as much per year than the standard person. So they're at a higher risk for these issues. I wanted today to try a little bit of a thought experiment or some empathy training. Imagine you had a chronic runny nose, and each time you reached for a tissue, it cost you $20. I imagine very quickly you would try to find ways to use less and less tissue. I imagine your quality of life would go down and people would treat you differently because you had fluid on your face. I imagine you would work less and your employer would say, you're not well, you can't work today. So you would work less and make less money. I imagine your providers might call you non-compliant and say, you know what you need? You need more tissue, and I have a box of tissues to sell you. I imagine you would start to feel extreme stress or anxiety every time you sneezed or sniffled. In a very small way, this is what our cancer patients experience day to day in the fight to survive. A little bit about me. I cut my teeth as a transplant social worker at Mayo Clinic. I quickly discovered the root cause of many of my patients' psychosocial issues were financial in nature. On my own dime and time, I started to study financial planning. In 2011, I joined Lakeland to build and lead its financial navigation program. And at that time, I had the opportunity to work with a consultant named Dan Sherman, and he taught me a lot about oncology financial navigation. In 2016, I completed my boards and all the requirements to become a certified financial planner. And I assume that I am probably the only financial planner working in direct patient care anywhere in the United States. So I think that kind of makes me a little bit special. My purpose, my calling, my why is to restore access to care. And so far, I've restored up to $50 million of care to thousands of patients, including some of the most high risk and vulnerable. I consider this to be health equity work, and financial navigation improves against health disparities. Behind the numbers, you're going to find satisfied patients with full access to care. You're going to find empowered providers able to deliver care as they see fit. And you're going to find a fiscally sound cancer system, respected by its community, because it's able to treat all patients, regardless if they can afford it or not. Financial toxicity is sad because we invest a lot into our national healthcare system. We spent $3 trillion on healthcare last year. And if you divide that by 300 million people, it equals about $10,000 per capita in healthcare spending for every single individual. And more, this per capita liability is being displaced onto the backs of patients and families. According to Kaiser Health, about the average family of four now has more than $20,000 a year in healthcare liabilities. And if you don't believe me, find your W-2 and look at box 12DD. This is not a big bonus from your employer. This is the amount that your employer has subsidized your healthcare premiums last year. Mine, what box said about $15,000. And that does not include the premiums that I paid or any of the additional out-of-pocket to receive care. As a certified financial planner, I understand a little bit about opportunity cost, which means a dollar spent on one thing cannot be spent on something else. So if you spend $5 on a cup of coffee at your local coffee bar, you lose the opportunity to invest or save that money. The same thing holds true in healthcare. Each dollar spent on healthcare cannot be spent on other options or opportunities. Warren Buffett uses the example of a $300,000 haircut. The concept goes like this. By purchasing for my present self a $30 haircut, am I willing to sacrifice for my future self, and maybe 50 years or so, up to $300,000 because I did not invest that money instead? Now, this is a really extreme example, but let's imagine what $20,000 per year is taking away from your future self and your family. Opportunities include $20,000 spent on a 30-year mortgage purchases a home valued at $300,000. It could end homelessness. $20,000 a year saved for a college plan exceeds a college plan exceeding $250,000 per child. It could end the education gap. $20,000 per year invested in retirement for 35 years secures a retirement valued at greater than $5 million. It could end poverty. These are many, many opportunities lost against the American dream. But for cancer patients, they may actually have lost their home or lost their kids' college education savings or lost their secure retirement. And on top of that all, they sacrifice even more. They sacrifice productivity. Many can't need to take a lot of time off work, and they lose their jobs during and beyond treatment. They may sacrifice their savings and resources, The Gilead study said up to half of cancer patients deplete their assets and incur medical debt. They may sacrifice their financial independence. Cancer patients are 3 times as likely to declare bankruptcy, according to a Fred Hutch study. They sacrifice access to care. Appointments and prescriptions are canceled and withheld due to cost. They can sacrifice relationships. People treat them differently. Support systems become strained. And sadly, they sacrifice time. Cancer-related financial toxicity can reduce survivorship and be terminal. After bankruptcy, cancer patients are up to 80% higher risk for death. This is a vicious cycle. Treatment comes with higher costs. You work less and less, leads to lower income. You deplete your savings and you get more debt. Next comes the distress, a lower quality of life, less support system, and finally, poor outcomes that lead to more and more care costs. The cycle continues downward until you hit rock bottom or you die. So our system is broken. It does not work very well, and it's going to get worse. It's estimated that 10 million people are going to lose health coverage because of COVID. This year alone, an additional 1 million people have lost coverage. And now as a nation, we have, again, we're above 30 million people without appropriate health care coverage. That's 10% of our population. And many, many of those patients are cancer patients. So you have a choice of how you're going to respond to this issue. You can either be the hammer or you can either be the glue. First, we have the hammer. The hammer is a hard tool and hard approach. Our current model is more hammer-like. The hammer may hold patients accountable and responsible, and it may get you paid, but it creates damage with each strike, and it comes at a cost. The hammer fragments our already broken system into more and more pieces and reduces continuity care. The hammer breaks relationships. After being hit, a patient tends to not want to get hit by a hammer again. So they avoid and withhold information, problems, communication, and trust from the provider. Many times I try to call our patients and they won't pick up my call because an hour earlier they received a call from collections. So they're scared to pick up the phone. The worst part is the hammer breaks access to care, and it increases stress because medical debt is nailed directly to access. Next, we have the glue. Glue is softer and sticky. It is more of a softer and sticky approach. Glue is a kind of a new model. It treats cancer-related financial toxicity as a side effect that needs to be treated. The glue sticks the broken pieces back together, improving continuity of care. The glue makes connections and resources and relationships a little more sticky. The glue will get you paid comprehensively more over time because patients and providers communicate better about problems, financial challenges that lead to earlier intervention, more options to help, and reduce stress. Most importantly, the glue sticks medical debt way far away from access. So it's pretty clear that financial toxicity is a problem. A lot of research has been done in the space, but not much has been done in developing effective treatments to help with the problem. So I decided to develop my own treatment model for support, and it's called HCR, or stands for Aid to Cancer. The first letter is A. Change begins with awareness. Change begins with knowledge. Very few people in healthcare seem to really understand how health coverage works. We need to learn more. Change begins with communication. Providers, you need to talk to your patients about financial issues. Simple open-ended questions such as, how has your cancer impacted your money and resources, can really help. According to the National Cancer Institute, only 1 in 3 cancer patients has had cost discussions with the providers. And out of the patients that have had discussions, 60% report improve satisfaction in relationships. Patients, you have to ask for help. I've had many patients miss important eligibility and options windows because they assumed nobody would help them. So patients, when you're in need, let's turn it around. And when your provider asks you, how would you like to pay today? And you can't afford it, let's turn that question around and say, I don't know, I can't afford it. How can you help me? And finally, assessments need to be individualized and focus on multiple timelines. Just because you're good and covered today does not mean that you will be good and covered in the future. So we need to look at the big picture. The next letter is I. I is for insurance optimization. We have a tiered healthcare system. It's part socialized, part free market, and part you're on your own. We can optimize commercial coverage by helping with HSA accounts, COBRA, and even ACA enrollments. Medicare is a cliff, and an opportunity. Many times I have patients come to me in crisis and say their prescriptions coverage has ended. And we quickly discover that they've fallen off the Medicare cliff because of new eligibility. So we can optimize Medicare patients by filling in those coverage gaps, enrolling them into secondary supplements, and finding them new prescription coverage. We're very lucky to live in a Medicaid expansion state. It acts as a final safety net for all of us. So we can optimize Medicaid by helping enroll people who qualify. Additionally, helping to find self-pay patients insurance is another way to optimize. There are always options out there. And finally, I've had patients transition through each and one of these options. Each transition is very, very high risk. So we can help them optimize by helping them navigate the transitions. D is for decreasing cost and bills. There are many ways to decrease the cost. We can decrease the cost by utilizing internal financial assistance programs or charity care, or finding external financial assistance programs, such as copay cards, foundations, and pharmaceutical patient assistance programs. We can decrease costs and resequence by maximizing services after deductible or MOB is met. At Lakeland, we've decreased costs by using biosimilar drugs. For example, we've saved about $500,000 this year by using the biosimilar for pegfilgrastim instead of the innovator. In some cases, labs and imaging can cost less at a freestanding center. In other cases, it can cost less to self-pay for a service, such as a lab or imaging or even prescriptions, instead of letting it go through your insurance. You know, for example, GoodRx. C is for coping. Too often, I have patients tell me that they're not going to do treatment because they can't afford it and they've decided to die. Too often, I have patients tell me that they're not worth the cost of care. Too often, I have patients share fears that they're going to leave their family mountains of debt. These are irrational thoughts and beliefs, and they can be restructured and listened to and turned into rational thoughts to improve coping. We can help cancer patients cope by teaching them rights and debt protections. Many assets are considered protected. Medical debt is unsecured. So for most cancer patients, in most cases, unless it's the last and final option, never, never, never put medical debt on a credit card unless you can pay the full balance in full before the interest hits. In most cases, never use your protected assets to pay for medical debt unless those assets are considered disposable. You got to meet your basic needs first and use only your extra disposable income to pay medical debt. Medical debt is lower on the priority list than basic needs. Basic needs come first. And in some cases, I even think that it falls below some quality of life needs. Cancer patients need to focus on quality of life. And finally, R is for restoring income and resources. We restore income to meet basic needs and quality of life, not just to pay medical debt. And we need to help patients access these restoration programs. Many income restoration programs might require provider buy-in, letters, completed forms, and signatures. Too often, this paperwork gets delayed and it falls through the crack because providers don't know what to do with it or even how to fill it out. So it's important to make this work a high priority and ensure people in the office are trained to do it. So what does that spell? It spells AID-CR, or known as Aid to Cancer. And as a financial toxicity treatment, AID-CR may improve the survivorship journey. I appreciate you listening to me today, and I look forward to your interesting questions. Thank you. Oh, and finally, this decision is yours. What do you choose?